Welcome everybody to our education and support classes that the University of Utah Healthcare offers. This is the first of a series of 8 classes that we offer to provide transplant education for our patients here at the University Hospital. My name is Shirley Balbo. I'm one of the transplant coordinators here at the University of Utah. Today's presentation is going to be on a general overview of transplant. And presentation, if you have questions related to material, please, we'd love you to ask them. Anything that's not related, we'll ask it after the classes, after the session is over. Okay. And so the beginning starts. You have to get here somehow. Usually it's a referral from your doctor. Some people refer themselves because they've just been sick for so long and they're seeking out a transplant center, and we get calls that way sometimes. But one way or the other, you get referred here, either it's yourself, your doctor, and then when we see you, you go through a complex evaluation. Typically that's 2 to 3 days of outpatient testing, unless you come in through the front door and you get admitted to the hospital. And then all that testing gets done as an inpatient. But typically the evaluation is 2 to 3 days, very, very thorough testing. Those of you that have had a transplant know that's a very thorough evaluation. Once you've completed the evaluation, you all get presented to your separate organ transplant committees for approval, for medical approval for a transplant. So this is a team of professionals within your organ, and they look at all the data, all the testing you've had, and all the evaluations from all the different transplant team members, and they look at all that very closely, and then they decide whether or not this is a good thing, a right thing, and a safe thing for you to have, okay? If the committee feels that this is a good thing, we go ahead and list you with UNOS. UNOS stands for UNOS. It's next slide will tell you that's the United Network for Organ Sharing, and they are kind of like our federal regulatory board for transplant in this country. There's only one board, and that's UNOS, okay? So you get put on the UNOS wait list, and then you wait, and you have your surgery, and then we cram all kinds of education in your head and give you all kinds of medications, and then we have you see us a lot for the first 3 to 6 months, but then it gets better and better, okay? Here's just a little slide. If you water them, maybe they'll grow, and then maybe we'll get some more organs. Here's a little bit on the history of transplant. Transplants have been around since the early 1900s. A lot of it was experimental before 1950s. First kidney was in 1954, and then the lung and liver and heart in the 60s. Basically, when transplants became approved by Medicare was when we started getting better medications to prevent rejection. And that occurred in the early 1980s. After that time, transplantation in this country started booming because we had much better drugs. Starting in the 1980s, cyclosporin came out. It was a wonder drug for transplant, and that's when most transplant programs started doing transplants. And shortly after that, 1985, Medicare in this country approved transplants. Once Medicare approves transplants, usually the private insurances follow. So everybody said it was okay, and it was a good thing, and it was no longer experimental. Okay. You've all got a transplant team. Your transplant team is composed of surgeons, transplant doctors. You've got cardiologists for the heart, and pulmonologists for the lung, and hepatologists for the liver. Transplant nurse coordinators and nurse practitioners, all the programs have them. Transplant assistants, your transplant assistants are going to answer the phone every time you call, do all your scheduling, and kind of coordinate a lot of things on the phone for you. Finance coordinators we have, which are vital to you because you've got to have the adequate insurance coverage. That's really, really important. Surgeries, most of the insurances will cover the surgeries, no problem. Medicare, Medicaid. It's the lifetime of medications that's going to really, really, really hurt you medicine-wise. Cost-wise, that's the most expensive cost to you. And so our finance coordinators can help you to make sure that you've got the good coverage. And if things change throughout your transplant, post-transplant with your insurance, they're always available for consultation. Social workers, we have a lot of social workers with our program, and they're going to help you with your relocation, with housing, and all kinds of other issues related to living here in Salt Lake, especially if you're not from around here. Pharmacists, we have 3 to 4 transplant pharmacists. They just specialize in transplants. They know the medicines better than anybody, and it's wonderful to have them. You'll meet with them. Every clinic visit you come, you'll meet with a transplant pharmacist and go over all your medicines, answer any questions you might have. We also have dietitians that will help you. You'll meet with a dietitian before transplant, and then afterwards they're available for consult if needed. Referrals. Our program here at the University of Utah is a bit unique because we are in the Intermountain West, and we just don't have a lot of transplant centers here. Our hospital at the University of Utah serves 6 states. We service Utah, Wyoming, Montana, Colorado, New Mexico, Arizona, and Nevada. So we service quite a few states in this area. Your evaluation, once you've been evaluated, and some of you have already been through that process, most of you here, yes, I think you've all been through that process, been through all the tests, had lots of blood drawn. What is next? Well, I hope you don't have to go to the sale to get your surgical organ. That's all I can say. What's next is you'll get listed with UNOS, okay? Remember I said UNOS, United Network for Organ Sharing, and they're our regulatory body for transplants. They're in Richmond, Virginia, and you will get listed based on your status, and that depends on, each organ has different status depending on your medical condition, your blood type, etc. We'll go through that next here. Factors that are common for all organs: you have to have the right blood type. Whatever your blood type is, the organ has to have the same blood type or compatible, right? Size, basically you have to have the same size match. If you're a petite person such as myself, you can't have a 300-pound football player's heart or liver or lung. You've got to match it out to your size. Your UNOS status, and we'll go over those here in the next couple slides. So those factors are common to all organs. Now, in between, now I'm going to just talk about the heart, lung, and liver, what's specific to each organ. With heart, okay, your wait time is a factor. If you have any antibodies, antibodies are protein substances that we all have in our bodies. You can develop antibodies if you've had pregnancies, blood transfusions, if you've had a heart pump. It just makes it trickier if you've developed antibodies. We can still get you an organ, we can still get you a heart. It just makes it trickier because we can't have, the donor organ cannot have those antibodies that you have, otherwise you'd have incompatibility. And all that gets checked out prior to you coming through the door for a transplant. So, statuses with heart, we have 4 statuses. 1A is the highest priority status. 1A is somebody that's very, very sick. They're in the intensive care. They're on life support, on a respirator, on all kinds of drips, pumps. They may be on machines. Basically, it's considered that they would die within 7 days without a transplant. So they are the most critical in the heart. 1B is the next status down. 1B is reserved for somebody that has a heart pump, okay, higher priority, but you're outside the community waiting, okay, you're not necessarily in the hospital. Now, if you do have a heart pump with the hearts, you do get 30 days of 1A highest priority status, and your surgeon will determine when you get that. And I believe that's when you got your transplant, during your 30-day golden window, we call it. Great, great. Status 2 is all the others waiting in the community. Okay, and 7 is yes. Mm-hmm.
How long can you stay on 1B?
1B, as long as if you have the heart pump, or if you have the other criteria, you have to have a continuous infusion of a heart medicine, dobutamine, milrinone, type of medicine that's going to keep your heart pumping. You have to have either one of those 2 things. You stay 1B until you get a heart, basically, or something happens. Okay, status 7. Status 7 is inactive. You are not actively, we're not looking for a heart for you. A lot of people get status 7 if various reasons. Well, if you lose your insurance, we're going to have to make you status 7. You've got to have insurance. What other factors? If you have an active infection, we would not want to put you on a list because after transplant, we're going to be giving you medicines that are going to weaken your immune system. That's how they prevent rejection, okay? And what happens when we weaken the immune system? Get infections. So if you have some kind of an active infection that needs IV antibiotics, we usually put you status 7 until such time as the antibiotics basically cure the infection and you're considered infection-free. Okay, then we put you back on the list. Okay. So with lungs, some of the differences with lung, they have a lung allocation score. They call it the LAS score. Okay, it's based on what your diagnosis is, your current medical condition, how sick you are basically, and your lung function scores, breathing test scores. Okay, the higher the LAS score, the lung allocation score, greater is your need for transplant and your higher priority. Okay. With liver, you have a MELD score or PELD score, and that score is based on 3 lab results: your serum, your blood creatinine, your bilirubin, and your INR, which is a reflection of your clotting factors. Okay. The MELD score goes from 6 to 40. Higher the number, the sicker you are. And they also have a status 1 with liver patients that are waiting. And those are patients that are extremely sick. It kind of crosses over to the 1A status of heart. It's a patient that would be in acute fulminant liver disease, less than 8 weeks. It's something that just occurred very abruptly. Okay, they just got sick last couple months. And they are not in the MELD score category. They're the highest priority, and they're considered urgent for liver transplant. They would be above the MELD patients that are listed. Scores or status definitely can change at any time based on your current medical condition. If you get sicker, you may get moved up on the list, depending on what's going on with your situation.
Who makes a determination?
Your doctors do, basically. That's why we...
Your person, I mean, your number one doctor or the team?
It's basically, well, it's a team decision. If you're getting sicker, your teams all meet weekly and discuss your cases. If you're getting sicker, it's usually a team discussion to move you up on the list based on that.
On the lungs, is there levels? It wasn't very
No,
clear.
it's just numbers, the LAS score. It's a lung
So-
allocation score, and it's numbers.
So how is the numbers? It's like
Depends on how sick you are. The higher it is, the more priority you have.
I know what my number is. That's what.
Yeah. So what you should do is ask your lung transplant coordinators. You know your number. Say, well, where is that on the list? Is that low priority, high, medium? Okay. Ask your coordinators is what I would do. Pick the one you like yet, if only, huh? The waiting period, that can be the toughest part. And some of you that have been through transplant, you might remember some of it. A lot of people just forget it all. I don't know if you remember much of it, Roxanne, but it can be...
I was like 4 hours in on 1A, and
Yeah.
I didn't know it.
Yeah, so you were lucky. But the waiting period can be a very difficult time for some people. We have had people on the list wait over 3 years for transplants.
3 weeks.
3 weeks, you were very fortunate, okay? I've had 8 hours, 8 hours to 3 years, 9 months in my organ. So it really, really varies, okay? During that waiting period, you will undergo repeating testing. You'll be seeing your transplant team as often as they think you need to be seen, depending on your medical condition, okay? We ask that you monitor your vital signs very closely and bring your records to clinic just like you'll be doing after transplant. Okay, that information is vital to your transplant team. Your vital signs, your weights, your blood pressures, your temperatures, okay? We ask that you do that before transplant, okay? And you're going to continue that after transplant to monitor yourself for any possible symptoms or problems, okay?
And be accurate in it.
Yes.
Some people I know just
Yes.
write the numbers down.
No. Be accurate. Be
Yes.
true to yourself. It's just yourself you're dealing with, yeah.
So do you have to go buy a blood pressure monitor and
Yes.
so on and so forth?
Yeah, would be good. Yeah, start early and get
Dumb
one.
question.
Yeah, no. So you're going to report any changes in your condition, if your vital signs or anything, your breathing, you're not feeling well, any change. It doesn't have to just be the vital signs. If you're not feeling well, you feel like you're sick, you call your transplant team. That is really important while you're on the list. Okay? Keep track of your medicines. Because medicines are big after transplant. They are. We got a lot of nods in the room here, okay? Yes, medicines are big. Okay, they're all different from what you took before. Okay, you get 2 or 3 anti-rejection medicines, and then all the other ones are to prevent side effects and complications, and there are a lot of them. But they're all there for a good reason. Okay, the waiting period, it can be a really tough time for people that are on the list for a really long period of time. It's unbelievably difficult. And then if we put you in the hospital and make you a higher priority status for what, we think you're sicker and you have to be in the hospital, it's even more difficult. It's a very, very difficult time. So all the support you can have from your family, your friends, you'll get support from the transplant team, but all of your family and friends is really important during that time. We ask that you attend all of our transplant group education classes because this will help you. You'll just be that much more prepared when you come time transplant. It'll be that much less stress for you after transplant. If you have an on-call pager, the only organ that has pagers now, I believe, is a heart transplant group. And just be sure you change your batteries. If there's anybody, I don't think there's anybody here, just change the batteries every 3 months on those. Everybody else has a cell phone, and that's how we reach them. So when you get ready for your transplant, lots of things you need to do. Basically, you definitely need to take care of all your affairs beforehand. It will really help in the long run. Most of the organs are required to, if you're not from this state, you need to relocate here. And that in itself, just relocating here, means that you've got to take care of your affairs before you get here. So most people that live out of town, they take care of those things beforehand. If you live here, it's a lot easier, but it's really, really important to take care of all that. Have somebody at home that can help you out with that. It would be great. Your caregivers are going to be important before and after transplant. You will need somebody with you for the first, just depends, usually for the first month or 2, depends on the organ. If you've had chest surgery with the heart and the lungs, you can't drive for 6 weeks because they're having open heart surgery. They don't want any injury there, cause any damage. So you have to have somebody with you. You'll have a lot of appointments, your doctors, to your tests, to your rehab. So you do need somebody with you for the first month or 2. Okay? Make sure you've got your living will and your power of attorney all set. Support group information, that's you get that from your social worker, transplant social worker. And you may be called in as a backup. You might have to come in, might have to go back home. There are false alarms, unfortunately. The transplant operation, there's the day. Transplant coordinator gives you the golden call, I call it. And there, once again, there are false alarms. It happens with every organ. When there's an organ that becomes available for you, the transplant and the organ procurement teams go through a very extensive process. And that's when things might come up where the organ may not be suitable, might not be good for you. And that's when the false alarms can happen. It doesn't happen all that often, but it sure can. And so just go in with an open mind, and just what happens, happens, and hopefully it'll be your organ, and if not, it just wasn't meant to be. Get admitted to the hospital. More false alarms. There'll be 2 surgical teams working. Usually what occurs is one of our surgeons always goes and retrieves the organ from wherever it is, okay? Go through the Intermountain West, okay? And then another surgeon is performing your surgery here. So we do always have a surgeon from our hospital that gets the organ, retrieves the organ, takes a good look at it. Sometimes that's when you can have a false alarm because they see visibly something wrong with it, okay? So it's good that our surgeons go out and get it.
What's the range on that they go out?
Pretty much the Intermountain West. It's pretty much that region, that referral region is
6
pretty much
states,
about the
6
same.
states.
Yeah,
Oh, okay.
yeah, yeah.
How many hours do they have between?
Every organ is different. So for heart, we have about a 4-hour window, and lung, I think it's
I believe it's 4, but for the patient, you have to be there within 1 hour.
right.
Yeah,
It's
for
about
prep
4 to
and all
6
that.
hours, I believe, for lung, and liver's about 10. Okay, and that's the amount of time that they have from when the organ is removed from the donor and placed in the recipient. So if it's out of town, they go by Learjet. okay? It's a very orchestrated procedure. We've been doing these for years. Everything has to be just so. There are nothing has to be, if something
No
goes wrong,
guesswork.
no hitches. If the weather is not good, many times that happens in our winters here, they don't go out, okay? So here you are in surgery, innie outie, out with the bad, in with the good. The transplant operation. When you arrive, you'll get to the hospital, check in at the lobby, you'll pick up your packet or folder, depending on which organ you are. Nothing to eat or drink. Medications, we'll instruct you when we give you the call what to do with your medicines. And then you're going to be inundated with all kinds of folks once you get here. You meet with your surgeon and your surgery team, you meet with your transplant team, anesthesia, the surgical nurses.
Here's a
and
pencil
everybody's
sign.
you're gonna kind of sort of get attacked, okay? Get your IV lines, get your blood work drawn, get your shower.
Signatures.
Yep, sign on the dotted line for the surgery. Yep. So the surgery off to the operating room, you wait. Sometimes the waiting for the organ, you know, it's real variable. It's difficult to give it time. You could come in and just think you're going to go right over and get it. Well, it doesn't work that way. So it just depends on where it's coming from. So just be patient. Things are all happening behind the scenes, believe you me. But it can be, sometimes it goes into past 24 hours before the organ arrives. So just
They
depends.
told me 3 o'clock in the morning, but it was ready at 12 o'clock that night.
Yeah, it just really
Mine was 10
depends.
at
It's
night,
just,
and
yeah.
9 at 2 in the morning.
Yeah, it just
of
really,
the
really changes. Yeah, it just depends. So off you go to the operating room. Depends on your organ, how long you're in surgery, really. Heart's about 4 to 6 hours, similar for the lungs and livers. I think they're all about the same. It just depends. If you have a heart pump in, which some of you had, surgeries take longer because they have to take your heart pump out before they put and then remove your heart. Your old heart before they put the new one in, so a little bit longer time on that. Back to the ICU after surgery. Once you go to the ICU, you're probably not going to remember a whole lot there. They give you a lot of medicines to forget, which is nice. You'll be on a respirator, and you'll have a lot of chest tubes, monitors, drains, lines, and things. They all new set of medicines now. Surgical ICU, they do have visiting rules, and the nurses that work in those units will go over those rules with your family. They're usually, they've really pretty much gotten lax on those. The only times they really like you not to visit is when they're doing their report twice a day, 7 a.m. to 8 a.m. and 7 p.m. to 8 p.m.
Or if you're
Otherwise,
having some kind of severe problem with
or if they're having a problem, they ask you to please
well, I
leave.
mean, if some of them gets infections,
Right,
you know.
just kind of depends what's going on in their
but
unit.
basically it's really laid back.
Right, they're very good about that. Now, the average stay is approximately 3 to 5 days, maybe a week in the unit. Just depends, once again, it's just a real variable thing. I actually had one woman leave in 2 days, which was kind of remarkable, but we've had people in there for a few weeks if they've had complications. It just really depends. Typically, 3 to 5 days, maybe up to a week, and then you'll go to the ward, okay, the surgical ward, when they feel that you are ready and you're stable. And that's pretty much when we're going to start some real heavy-duty education, okay, depending on where you're at. If you've been to these classes, you'll be well educated, okay? You won't need as much teaching, but we will not let you go from the hospital until you get the information you need. We'll provide you with your medications for a month, and then the transplant pharmacist will help you to figure out where you're going to get your medications filled and all that kind of stuff, okay? And then you will also be enrolled in a rehab program because now we've given you a new organ. This is a new life, and we want you to have a life. We want you to get stronger and better and start feeling good so you can live. And there you are, change of heart. Planning for discharge, we discussed that, about 7 to 10 days average in the hospital, overall up to 2 weeks, I would say. And like I say, we go through some extensive education with you and medication teaching. After discharge, you do need to stay in the Salt Lake area for a period of time until your transplant team releases you. And that is really variable. For heart, it's 6 months. What did they tell you for lung?
It varied, at the least 9, I think.
Yeah, yeah, it just depends, and
Nine,
livers
how
are
many
all,
weeks or months?
yeah,
Months.
9 months, yeah, it really depends, and I think liver is about 3 to 6 months, so just depends.
I think they said lungs are the only thing that takes something from the outside.
Right.
And that's
Right,
why it's
right,
harder.
more source of infection with the lungs, so that's why they want you to stay longer, exactly, yeah. You do need to have a designated caregiver, especially for the early part, when you can't drive. After a period of time, your transplant team may allow you to just be on your own, and you just can discuss that with them, okay? No driving for 6 weeks, or mostly per your transplant surgeon. You need to have a lot of blood draws, clinic visits, tests, procedures, and all of the organs require a period of rehab and physical therapy to get you stronger, which is a good thing. Complications, well, you know, transplant's not without complications. The biggest things we worry about are infection and rejection, but there can be surgical or medical issues that occur, you know, throughout your hospital stay, okay? And then there's all these new drugs we're giving you, and you can have side effects from those, okay? And they can start early on, you may not have any, it really varies, but there are complications with transplants, and your transplant team will go over all that stuff very, very thoroughly with you after transplant and teach you what you need to look for, what you need to report to your transplant team, okay? That's some nasty rejection. Get that out there. What is rejection? It's a funky word, it's a scary word. Basically, it's a normal response to something that we put in your body that's foreign, okay? All transplant recipients do experience some degree of rejection, okay? Most rejection is treated and controlled with adjusting your medicines or changing your medicines around or maybe adding some different medications, okay? But it is something that is treatable, okay? Most people do not experience any symptoms with rejection. You can feel fine, okay? The biggest concern that we have, you say, well, why do I have to be treated? I feel fine. And then we say, well, you had a mild rejection, you had a moderate or whatever. You know, the concern is long term. If we let that go, it could turn into maybe moderate and severe rejection. And then you're in big trouble. Then you're back in the ICU. That's why we want to treat it early on with medications to control it, get rid of it. Symptoms of rejection, they're very vague. I wished I could tell you there was one little symptom that you could say, oops, I'm having a rejection. There isn't. They're very, very vague, and like I said again, you may not even know you're having a rejection. A lot of people have no idea, okay? You can get short of breath, you may have weight gain, you may have symptoms that you had all over again prior to your transplant, okay? Fevers, you just don't feel right. It's a common thing people say, you know, I have not really been feeling good for the last couple months. And that's a hard one. You know, that's a really hard one, especially after your surgery. Well, you're not going to feel right for the first 3 months. And that's nothing to do necessarily with rejection. That's because you just had a big major surgery. So these are very subjective symptoms that are hard. Fatigue, well, of course you're going to be fatigued for quite some time after your surgery. It's going to take you a while to get your energy back up. That's why we have you all in rehab program. Get your strength and get your energy back up so that you can do the things you want to do in life.
When you go
Might
back
have no
up-
symptoms at all. Very good.
When you get a sudden weight gain, I mean, once I got my heart, man, I just got hungry. I mean,
Well, that's another,
Especially
so then
after-
that's up to you, that's a very good point. That's really up to your transplant team to determine, okay? Most people get put on prednisone. I believe all the organs use prednisone for an anti-rejection medicine, okay? Prednisone can cause people to have an increased appetite.
well, the food even tastes better.
Okay, that can be
I
good
mean,
and bad, and
as
that can be
opposed
good
to
and bad. The
hospital
food
food.
tastes better, okay? But that's really up to your transplant team to determine whether your weight gain is just food or whether it's a symptom of rejection, okay? So if you are gaining weight, that's something they'll discuss when you come to clinic after
Well,
transplant.
they told us 3 to 5 pounds is not bad, but, you know.
Right after that.
Poof, yeah.
Yeah, yeah. Treatment depends on the grade, again, mild, moderate, severe. Every organ has different grades of rejection, and it also depends on how you're doing, okay? If you're showing other clinical signs based on the different tests they're doing, that the organ is deteriorating, then that makes it more severe, okay? You may be treated as an outpatient, or you may need to be admitted depending on the severity of the rejection. Typically, we give a little extra prednisone or oral pill form or IV form. We may add new medications or change the doses frequently is what we'll do with the medicines.
I think that if it's something that's not normal to you, because nobody knows how to act, because you've never been through this. If it's not normal to you, I think you should report it.
I agree. Roxanne is saying if you're feeling something not normal that you're not used to, you didn't have before, you should report it. Definitely, I agree, yes. That's important.
I have a friend that had a liver transplant 10 years ago, and she told me she had to have it in Omaha, Nebraska. And she said she went there for her appointment, she had felt fine. She passed out in the office. She had to have another liver. She had no signs.
Yeah.
So, but she was going there for her testing,
Yep. Yep.
and she had that
Yep.
for 4 years.
So, Roxanne is saying, and someone she's familiar with had a liver transplant that felt fine and went to their clinic after transplant for a routine visit and was very sick and had to have another liver transplant. So, it is, and that just goes to show you, and that's exactly what it is. It's a very subjective thing. You just frequently, you don't know. I remember my first week here, I had a patient that was a couple months post-transplant. He came down, he looked great. He had a severe rejection. So, he had no symptoms. So, you just don't know.
In other words, get tested.
Get tested, and here's the test for rejection, speaking of. With the heart, now we'll go through each organ individually. With the heart, the way we test for rejection, we do heart biopsies. We do heart biopsies once a week for the first 4 weeks, and then we space it out to every 2 weeks, month 2 and 3, and then it goes to monthly, every other month, and then after a year, we start doing AlloMap. AlloMap is a blood test that we have that helps to determine rejection, okay? Looks at rejection a little bit differently than a biopsy. A biopsy is going in to your right jugular vein, and it's snipping 3 to 4 pieces of small microscopic tissue, okay, and that gets sent to our pathology for analysis. So they're looking at the blood vessels and the cells under the microscope, and that's how they determine rejection. That's kind of our gold standard in heart to determine rejection is a biopsy, okay? If you do well, you don't have too many problems with rejections. After 5 years with the heart, you won't need any more biopsies, okay? They are performed outpatient in the cath lab, similar to the right heart cath that you had to have prior to transplant with the heart. Okay, it takes about 45 minutes to an hour. We do receive the results usually the next day. We always do an echocardiogram to check your heart pumping function when you have a biopsy. And like I said, AlloMap is now a new test that has come up in the last 2-3 years to help us determine rejection with heart transplant. Looks at rejection totally differently. It's a molecular gene expression testing, so it looks at DNA and RNA, okay, and that's a test that you get done. We get those results usually 2 days later. It gets sent to a reference lab in San Francisco. That can be done at 6 months, but not before. Your prednisone dose has to be down below a certain level. Excuse me. And that's something that can spare you of having to get a poke in the neck. So that, and if you're not sure if you qualify or not, you should talk to your transplant team about that. You have to go to a center where they offer the AlloMap blood draws if you go back home, so that can be an issue.
What's an RNA, you said?
DNA or RNA, just that's kind of like your immune system, part of your, looks at your immune system.
The RNA does.
Yes, DNA, RNA.
And what does that stand for?
RNA, ribonucleic acid, I think it is, yeah. So that's just looking at your immune system. Just a different way of looking at rejection and looking at cells under a microscope. They've proven it to be a very useful and valuable. Unfortunately, they don't have this test for lung yet. They are looking into it for lung, though, and they're doing studies. And they don't have it for liver transplant. So, unfortunately, hopefully that'll come with time. So with lung, the tests that they perform for rejection are bronchoscopy. You're very familiar with those usually. Prior to transplant, you've had a few. They do them every 2 months for the first year. And then they just basically, they're done as needed, depending on how you're doing. If you're having symptoms, you're having more problems breathing, whatever, your lung function tests go down, then they will probably going to be they'll be performing a bronchoscopy, okay? And the bronchoscopy inspects your airway, they wash out your lungs, and basically they check a biopsy, same kind of a thing that goes under the microscope to look for rejection. With the liver, there's liver function tests are drawn, and this is just a blood test that you get. You get that very, very frequently with the liver transplants. You do that 3 times a week, and that gets decreased over time, but that's the main test that they use to determine rejection, okay? Liver biopsy is not something they do that frequently, just kind of just depends on your situation, if you're having any symptoms, if your liver function tests are elevated and they're concerned, they may do a liver biopsy, okay? Once again, based on your liver function tests, it is something that is done in the X-ray department, in their interventional radiology department. They do it under guided ultrasound, so they know where they're going. It takes about 20, 30 minutes, and they get the results usually the next day.
Kind of like a heart biopsy?
Similar, but with the liver, yeah.
Okay.
So, calling your coordinator after transplant. This is kind of big. We want you to call us. We don't want you to hide. We are part of your team. We are family, so please call us if something comes up. Now, what we ask is you call the office during office hours, 8 to 4:30, if it's for something to do with appointments, your medication refills, or just a regular question that's nothing that's, real serious, okay? Like you're having some kind of a side effect or a symptom or you don't feel well, okay? Call during the day, but if this something develops at night or on the weekend that you are concerned enough about, you develop a high fever, you're sick, you're vomiting, you don't know what to do. You just don't feel good, you don't know what to do, you're scared, you call us. We're always, always available. Coordinator is on call 24/7 every day. We don't take holidays, okay? We are available through the hospital operator, and there's a phone number. You'll all get the phone number. You'll all know the phone number very well, very soon. You don't know it now by heart. So you make sure when you call the hospital operator at this number, 801-581-2121, you ask for your specific organ coordinator, because a lot of times what they'll say to the operator is, I need my transplant coordinator. Well, we do 6 organs here. So, make sure you specify, I need the lung, the liver, the heart transplant, whatever organ, so they can get your correct organ coordinator, okay? If it's very, very serious, 911 is always available. Please don't hesitate, and that's why it's there for. This is if it's a life-threatening medical emergency only. Oh, just a little joke for you all there. Okay, potential risks, problems that can occur after transplant. There are problems that can occur. You do have increased risks for cancers, and that's because the medicines, the anti-rejection medicines that you will be taking for life, they're proliferative. So you have one little cancer cell in your body, can grow, okay? So what we ask that you do is you do your routine cancer screening every year, and your transplant team will go over what your annual screening is. It will include cancer screening. There's no one test to prevent cancer. I wished we had it, but we don't. But they'll have you do a routine colonoscopy every 5 years. They'll do some specific blood tests. Females, they'll have you do mammograms, pap smears to check for cancers. Males will be checking prostate antigen blood tests for prostate cancer. We do everything we can to screen for possible cancers. But once again, there's no one particular test. So whatever we tell you to do, please do it. Because if this gets missed, it can be very, very serious. And if that cancer progresses, it can really be a lot worse for you in the long run. Early detection with cancer is the best for success, okay? Kidney disease, unfortunately, those medicines we give you, again, they can wreak havoc with your kidneys. They are nephrotoxic, which means they can hurt the kidneys. So it's basically up to your transplant team to keep those levels of your transplant medicines as low as possible so we don't have rejection and we don't hurt the kidneys. That's our job. Leave that up to us, okay? But typically we do not leave the levels high. Oh, that's good enough. No. We want to make sure we have the lowest possible doses so that you do not have rejection and we do not hurt the kidneys, okay? Bone disease, that can be from your medicines also, so we will possibly have you have bone density scans, and we will also have you on preventative prophylactic medication to prevent bone loss after transplant. Calcium supplements, vitamin D, Fosamax if you're on the prednisone, which helps to prevent bone loss, okay? Coronary artery disease is something, unfortunately, that's the number one thing that can get you after transplant over time. How can you prevent that? I just got a heart. Why do I get coronary artery disease? I just got an 18-year-old's heart or lung or liver. I don't understand. Well, it's actually a process they don't understand, the doctors either, okay? It can happen. What we ask is you do the best you can in taking care of your organ. You do good heart health. Even if you have a lung or liver, we want you to maintain good heart health, which is keeping your blood pressure in good check, eating a good heart-healthy diet, low fat, low cholesterol, and exercising regularly. You don't have to do any fancy exercising. Walking is the best form of exercising. Just walking every day on a regular basis, 3 to 4 times a week, is something that you can do that's very easy, simple, and cheap. So keep that in mind. And those are things you can do to help prevent the coronary artery disease from developing. We also will put you on some medicines to help control your blood pressure and your cholesterol. And some people say, well, why am I on statins? Why am I on cholesterol medicines? You told me my lipid panel was fine. Well, that's to help prevent anything from happening. It's basically good heart health so you don't develop this. So a lot of times we'll put you on the statin mainly for prevention, even if your lipid panel is good, okay? Depression is a big problem, actually. And if you think about it, it's kind of a roller coaster ride you're going through. That's the way I look at it. You're starting out, you get evaluated, and you get all excited when you get on the list, and then you wait. And that can be really depressing. That can be one of the most depressing times. You get through that, and you get the golden call, you get the organ transplant, and then you're on cloud 9 that day. You can't even believe it. This is it. Life is going to be good. I've got a new life coming here. Then you leave the hospital. 30 days later, 60 days later, reality hits, and you've got a pile of medicines. You might not feel that well right away in the first month or two. Yeah, someone's smiling, yeah. Yeah, it's tough, it is. And people get depressed, and there's nothing wrong with taking antidepressant medicines. If the transplant team feels you need them, you should take them. There's nothing wrong with that. Absolutely nothing wrong. If it can help you to get through this period, it's a good thing, okay? Vision changes you can have. Prednisone can cause some blurry changes with your vision. People nodding their head in the audience. Typically, when the prednisone doses start going down, those changes will go away. So we ask that you don't try to just kind of get through it for the first 6 months. We ask that you don't see an eye doctor until at least about 6 months. Unless you're having some major problem. I mean, that's, eye problem, that's a different thing. But if it's just changes like blurriness, which is the most common thing with the prednisone, things are kind of out of focus and moving a little bit there, that will go away with time. Give it at least 6 months before you see the eye doctor, okay? Health maintenance. We are going to ask that you take good care of yourself. And every year, we're going to ask every 1 to 2 years, depending on your organ and how old you are, we ask that you get an eye exam. There are increased incidents for cataracts with the medicines that you take. No matter how young or old you are, I've had some of my patients in their 30s develop cataracts after transplant. Not a big deal nowadays. Cataracts is an outpatient surgery. You're in, you're out, it's done. But what we ask is you, once again, get an eye exam regularly so that we can find out if there's any issues or concerns that we can take care of. We ask that you have a skin exam by a dermatologist or a local primary doctor if you don't have it. If you live in a small town, there's no dermatologist, you can go to your primary doctor, but you do need a thorough skin check once a year. And that's to check for skin cancers, okay? You can't look at every part of your skin and your front and your back. We ask that somebody get a good, thorough look. And if you see anything suspicious, any change in a mole or a new lesion on your body, and it doesn't go away, and it seems to be getting worse, you should talk to your transplant team. They may want you to see a skin doctor about that. It may be early skin cancer, okay? Skin cancer is very easily treated nowadays. Once again, early detection, okay? If you're female, will ask for routine pap smears and mammograms every year after age 40, the mammograms. And also you should be checking your breasts monthly. Males, you should get a prostate exam every year. Also be checking your testicles, just like women check their breasts. Lumps and bumps, you notice something abnormal, you talk to your transplant team, okay? And then they'll further direct you. And then again with the males, we do check the blood test, the prostate-specific antigen yearly. That's just a general screening. Just because it's negative doesn't mean you don't have it. That's why we also ask you get an actual manual exam from your family doctor every year, okay? Colonoscopies every 5 years unless you've got any problems, and that's just routine after 50, so. Dental follow-up, we do recommend that you take antibiotics before each visit to prevent any problems with possible seeding of infection into the gums and the bloodstream that will go into your heart and cause endocarditis. Have seen that. So make sure if you're getting any dental procedures, you contact your transplant team to see if you need antibiotics before, okay? And immunizations. We want you to get immunized after transplant. Usually we wait 3 to 6 months after transplant before we start with flu shots and whatnot. We do also recommend that you get your tetanus every 5 years and a pneumovax injection every 5 years they're good for. Flu shots are every year, we recommend, after the first 6 months. Going home, yee-haw. Nothing changes because you're going home. You still have to have a doctor at home, just like you had before. And we ask that everybody have a primary doctor because a lot of you folks live out of the community. And we can only do so much to help take care of you on the phone. If you're having a problem and you need a doctor to see you, to check you out, we're going to ask you to go to your primary doctor. So if you don't have one, you need to get one. That's imperative, okay? If they have any questions, they can always call. There's always a doctor, a fellow, or a coordinator available 24/7. Call the hospital operator if your doctor wants to talk to your transplant team, okay? You will have routine labs and tests for life. That won't quite go away. Live and enjoy life. That's the reason why we transplant you. We hope this is going to give you a good quality life. That's the whole goal. That's it. Thank you, everyone.